All right, hello and welcome. This is Dr. Michael Wasson from Arizona Jaw Surgery, here hoping to make a roughly 20-minute TMJ video for you. If it goes a little longer, I'm sorry, but I'll do the best I can. And the whole purpose of this is to provide some education and also some treatment resources, some evaluation resources that maybe will help save you some time, money, unnecessary treatment, unnecessary cost in your TMJ or facial pain disorder. So let's give it a shot. Here we go. So I'm Dr. Michael Wasson, Arizona Jaw Surgery, as I said, practicing out of Scottsdale, Arizona. So some basic advice that I would give you and most people is how to choose a TMJ provider or TMD provider, whether that's a surgeon, a non-surgeon, or whatever. So first and foremost, avoid closed-minded people, people who think that all their patients get better. They don't really listen. No one ever needs to be referred. No one ever needs surgery. I've got it all figured out. I can tell you of over a decade of doing this, the people who do this frequently and correctly know that this is a challenging thing to deal with. And not everyone is the same. Not everyone gets better. Not everyone gets better the same speed. It can be a challenge. So avoid closed-minded people. You don't want someone who has a one-size-fits-all. Meaning that means that they just treat everyone the same. So no matter what you actually have or what you're saying, you get X, Y, and Z, okay? You also want to see someone who has a lot of tools. So what I mean by that doesn't necessarily mean that they do everything under the sun or they have everything in their office, but they have referral relationships. I have a physical therapist I work with. I have an orthodontist. I have a dentist. I have a surgeon. And then I do a lot of things so that I can provide you what you need instead of just forcing you to get what I can offer you. And so you may not get the right treatment. People recommending dental related treatments, avoid that. Okay, we'll go into that a little bit more, but trying to move your teeth, change your teeth for treatment of your TMJ disorder, we know that doesn't work. We know that leads to problems, issues, expense, and other things. So again, in my world, people who say they want to use surgery only as a last resort, all the while you're in pain, all the while your quality of life is affected, all the while your life, your work, your social, your romantic life is suffering. You want to avoid people like that. That's generally people who are practicing as if we're decades in the past. And what I contrarily would recommend you find is people who are open-minded. They listen. They want to hear what your actual problems are. They want to find what your actual diagnosis is and get you what you need because they have a large set of tools, whether that's they themselves or referring people that they work with, okay? And that way you get individualized care and you're not just forced into a tiny little box that they have and this is what I do, so this is what you get, okay? And with AI nowadays, you can more quickly, easily check who's performing evidence-based care. Take out your ChatGPT, your Grok, your Gemini, whatever you use, and just simply ask, is this treatment evidence-based, or what is the level of evidence for this treatment for temporomandibular joint disorders or muscle disorders? Okay, so getting into this in a little more detail, what is TMJ, TMD? TMJ is just your joint, your temporomandibular joints. You got two of them on the side of your face. They help you open and close, move your jaw left, right, up, down, whatnot. TMD is an acronym. That's a temporomandibular joint disorder. I don't really like these terms. The way that we use them, I kind of say that they're garbage terms because we use them in the dental world, especially in the medical world, to just describe you having some kind of pain in your face. Okay, and that's confusing for you. That's confusing when we try to communicate between providers. It's confusing for insurance companies, everyone. So when we can kind of more clearly identify your problem as a muscle problem, you have myalgia, myositis, muscle pain, muscle soreness versus an actual joint disorder, we can communicate, we can treat, we can identify much better. So ideally, that's what we would do, but inevitably, you're going to deal with this terminology, okay? For the sakes of this discussion, we're going to discuss more common temporomandibular joint and muscle pain disorders. There are extremes. There's fractures, there's tumors, there's more advanced disease, there's systemic arthritic conditions, idiopathic condylar resorption, which are a little bit beyond the breadth of this discussion. Trying to fit it into 20-ish minutes, we got to leave some stuff out, okay? All right, so helping identify if the problem is muscle or joint is huge because that changes how we treat it and what our treatment options are, okay? Most of the time, this is muscle. Roughly 90% is the number that's frequently thrown around. Not sure that's entirely accurate, but probably pretty close. And it can be both, but tends to be predominantly one or the other. It's one is the chicken, one is the egg, so to speak here, and causes the other to come around. So how do we determine which one it is? You can often do this on your own. And just with this information here, I hope that it helps you, because that is crucial. And muscle pain tends to be generalized, meaning that my face hurts, my jaws hurt, I have frequent headaches in my temples and the sides of my head. It's hard for me to take a finger and say it hurts right here, because it's more like all here or all here. And that's generally very common in muscle pain. Okay. People feel like they sometimes have tooth pain. They'll get their wisdom teeth out because they have this, or they feel like they need a root canal or other things, because it's just generalized soreness and pain that can go and feel like it's into your teeth. Actual TMJ pain is easier to localize, meaning you can take a finger and say, it hurts right here. When I chew, when I put force or bite down, it hurts here. And when I chew or open or yawn, it pops here and it hurts. It's just a more specific place, generally in front of or around the ear. Again, you may have sounds, you may not. You may have previously had a click and now you don't. May or may not have a big component to why you have a problem, but can correlate with this. Okay, so again, summary of how to differentiate these things. Muscle pain, broad, diffuse, hard to pinpoint, hard to localize. It may be the head, it may be the side of the face, it may feel like it radiates up and down the jaws, headaches, all that. TMJ pain, localized. I can pinpoint it. It's right in front of my ear. Sometimes feels like my ears are clogged or other things. I may have sounds. And then the other big one is when you try to open or move. Both of these can limit how much you can move, but when it's muscle, you tend to be able to fight through it a little bit, meaning I'm stiff, I'm sore, I can't open my mouth, but if I force it a little bit, it just feels like I'm stretching a tight muscle, but it will continue to move. Often TMJ actual joint problems, you try to move and it feels like something's preventing you. There's something actually physically impeding you from being able to open. You can stretch, you can try, and it just doesn't move anymore. It's not necessarily pain that's limiting you. That's a sign of a temporomandibular joint disorder. So too, if you try to open and it's only on one side, that means the other side can move. So when you open, your jaw tends to deviate to the affected side. So if it's your left side and you try to open, things will deviate to your left side. And with muscle pain, it's often associated with hyperfunction or parafunction. So people who are moving their jaws all the time, whether that's clenching or grinding while awake or asleep, if that's chewing gum or just like they wear their tension in their jaws, and when they're stressed or focused or thinking during the day, they clench down. All of these things tend to be more representative of muscle problems. So as we start to treat these things, there's some general principles that we can go to help us, and these are very important. So here's some do nots. So do not stay in treatment for an extended period of time doing the same things over and over with the same person or on your own without getting results. There's risk to this. You can get chronic pain, which can be a lifelong condition. If you're just in pain for an extended period of time, you can develop chronic pain, which is a different type of pain and can be lifelong. So don't just keep doing the same thing over and over. You have to advocate for yourself. If you're working with someone and you like them, you trust them, you respect them, but you're just not getting better, you have to advocate for yourself, okay? Think of it in this terms. If you're the right patient for the right provider who has the right diagnosis, treating the right condition the right way, you should be getting better. And if you're not, you need to stop, reevaluate things, advocate for yourself. Generally, I say around 12 weeks, which is 3 months. You don't want to go much beyond that. Again, you don't want to develop chronic pain. You do not want to change your teeth in order to treat your temporomandibular joint or muscle condition. We know these things don't work as far as treating the TMJ. There's good reason to have orthodontics. There's good reason to have expansion. There's good reason to have crowns, restorations on your teeth. But to do it for temporomandibular joint problems is not evidence-based. It's not backed by science and tends to lead to more expensive and complicated treatment, all while you're not getting much better. I would also say, contrary to what you'll hear and see, don't buy an expensive splint as a first-line treatment. If you grind your teeth in your sleep, then yes, a splint is necessary to prevent you from damaging your teeth, but it's not going to necessarily help your TMJ disorder, okay? So don't spend a lot of money on that unless you're clenching, grinding your teeth. And really, a cheap one that just protects your teeth is all you need. Again, if you want to check the level of evidence and confirm that splint therapy is not well proven to treat these disorders, ask your AI. Okay. Other principles. Treat a muscle injury like a muscle injury. Treat a joint problem like a joint problem. When we adapt these orthopedic type principles and treat your joints and muscles like any other joint and muscle in your body, we get excellent results efficiently. Okay? Not a hard principle when you think about it. It's just pretty straightforward. We don't have to make these things overly complicated. So if you have a muscle disorder, the principles for this are pretty simple. We'll go through them in a little more detail. First and foremost, you got to be consistent with this stuff. No one can do it for you. No one's coming home with you. If you're just doing things here and there and you're not taking it seriously, you're not going to get better. And that hurts us on a lot of levels. One, you're not getting better when you could have. Two, we as the providers don't know if you would have gotten better. So if you had done these things consistently for weeks to a couple of months, would you have gotten better? That's good, useful information for us, because if you don't do it and you're just doing it here and there, we lack that information to know what would have helped you avoid unnecessary cost and treatment. And also it clouds the picture for us trying to figure out what's wrong with you. So mostly if you can remove the cause, if you're chewing gum, if you're clenching, if you're grinding, if you can improve upon that, that will help. The clenching, grinding in your sleep bruxism is tough because you're not doing it on purpose. You're not even doing it when you're conscious. But as much as you can to remove those things, rest, do NSAIDs, some physical therapy, those things will help you. So in a little more detail, again, you have to be consistent. If you're just not doing all this and you're doing it one day and then 2 days later you're not, you can't half-ass it. You really got to do it, and it will take weeks generally to see improvement. So soft diet, what does that mean? If you have a fork and you have food on the plate, you should be able to push the fork through the food and it go through to the plate. If you can do that, it's okay to eat. You can go to more extremes and just try not to chew at all for a few weeks to see if that helps. But that's a really crucial one. You don't want to be biting and chewing a lot with these jaws that are sore. Physical therapy, what you're seeing on the screen is maybe an exaggerated example, but you could do this very simply with a finger down, thumb up. Just stretch. Okay, we recommend 5 times a day doing 5 reps. And what I consider 1 rep is massage your cheeks here for 10 seconds. Stretch and hold gently, 10 seconds. Massage 10 seconds, stretch 10 seconds. That's 2. Do that 5 times a day. Breakfast, lunch, dinner, right when you wake up, right when you go to sleep is an easy way to do that. And you can do it more. You can't do it too frequent, but what you don't want to do is be too aggressive. You don't want to stretch it aggressively and injure yourself more. You just want a stretch, okay? Physical therapists are great for this. If you have one that you trust or know that does TMJ stuff, they can help you. And then NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen. There's a lot of others out there. I kind of like naproxen because it's a little easier on your body. You only have to take it twice a day, but you want to take it on a schedule. So you don't want to just take it when you hurt. You don't want to take it here and there. You're really trying to calm this inflammation and soreness down. So naproxen's easy. You just take it every 12 hours. So twice a day you take it. Do that. Again, we don't want you doing that forever, but for a few weeks to a month to help calm things down is a reasonable thing to do. And if you do those things, just those things right there, consistently, diligently, and seriously, it would be unusual for you to not see improvement from a muscle disorder. Does it mean you'll get completely better? Does it mean you'll stay that way forever? No, but periodically you may have to do these things to help you calm things down. So if you do those things and you're not getting better, you should pause. You, your provider, whoever you're working with, or if it's just you, think about things. We may need to reevaluate things. I did the treatment for muscle disorders diligently for a few weeks to a couple of months, and I'm not better. Well, do we need to get imaging? Do we need an MRI? Do we need a CT scan? Am I not getting better just because this is severe and I can't stop grinding my teeth? Did we misdiagnose this? Is this actually a joint disorder? Okay, do we need to use adjuncts? So if it's truly just a muscle disorder and we feel really confident in that diagnosis, we can throw in things like muscle relaxants for you to take at night to help with the clenching and grinding. You could do Botox. These are not great long-term solutions. There's side effects, there's cost, there's expense, there's time. I don't know that you want to be injected every 3 months for the rest of your life with Botox. But if we need to help calm things down initially, or if you get a flare up here and there, these are other adjuncts that we can throw in there. but doing these things consistently will generally calm things down. Well, what if it's an actual joint disorder, an actual TMJ disorder? Historically, we would treat these the exact same way that we just went through. All of those tools we just talked about, we'd use to treat actual joint disorders. Not unreasonable to do that. That's a reasonable thing to try, and you may get sufficiently better. Do the soft diet, do the stretches, do the NSAIDs. All those things might help you. But don't do them for too long. If you have a joint disorder, again, we like to say no more than 12 weeks, 3 months, because the sooner we get you to the other option, the better you do. And we now have decades of research showing that minimally invasive TMJ surgery is actually more effective than non-surgical treatment in every aspect, meaning pain relief is faster and more, better movement of your jaw, better diet, better quality of life, usually less expensive because you're not just treating it for months and months or years and years. So every metric is usually better when we do minimally invasive TMJ surgery. And if you don't believe me, again, ask AI. Ask it, what is the level of evidence for minimally invasive TMJ surgery compared to non-surgical therapy? So what is this? When we say minimally invasive TMJ surgery, what we're talking about is arthrocentesis and arthroscopy. And it's surgery without a true incision. We're not directly opening the joint to access it and get in there. What you can see on your screen is immediately after arthroscopy. These are tiny little incisions, okay? This will heal up great. They will not be noticeable. You'll see in females, we have to often shave the hair, and as the hair grows in, you won't notice this at all. If it looks like anything, it'll look like a freckle or a little dimple, but generally when it heals, you don't even notice it. So we're going and accessing the joint through needles, cameras, and other things, cleaning it out and putting medications in. So here's an example of arthrocentesis. So all we're doing is putting a couple needles in the joint, flushing it with a bunch of fluid to clean it out, hopefully expand the joint, help relieve some of the scar bands and adhesions. And then once we've done that, we just inject some medications in there to help calm the inflammation down, okay? Now, for arthroscopy, it's a little more involved, but also a little bit better. So what you're seeing on your screen is a surgical arthroscopy. This is a patient who was in non-surgical treatment, doing the same things over and over again for 3 years. We did an arthroscopy, and we found a tumor. What you're seeing in there is something called synovial chondromatosis. So I'm going to say this again. Advocate for yourself. Do not be in treatment for extended periods of time when you're not getting better. Don't think that, hey, the third, fourth, fifth month is going to be different than the first 3. Suddenly doing the things that weren't working are going to work, okay? Biopsy the tumor, had to go in and take this out in a different way. So here's the advantage of arthroscopy. We're directly visualizing the joint through a camera, okay? All through those tiny little incisions. So it's our best diagnostic tool. We can see things like this. We can see how your disc appears. Is it out of position? Is it perforated? Do you have scar bands? Do you have a tumor? We're getting the best quality diagnostic information, and then we can treat it at the same time. The problem with this is that not a lot of people perform this procedure, and even fewer people do surgical arthroscopy like you're seeing on your screen now. So it can be difficult to find providers, but this may be worth traveling for if you have people reasonably close or you're willing to travel, okay? So again, the diagnostic component is huge, and it's why we often get better results than arthrocentesis. So key points to this: ask AI. It is the best treatment option for intra-articular actual TMJ disorders, but we have to get to you soon. The sooner we get to you, the better the results. If you wait too long, your disease may be more advanced. We may not be able to adequately treat you with minimally invasive surgery. You may need more advanced surgery. And when we compare these to non-surgical treatments, the reason we get better results is we're treating the actual problem. Your problem is in the joint. We're treating the joint. And the difference is you may no longer be a TMJ patient. When you're treating something non-surgically, you're trying to calm it down and overcome the problem. You're not actually treating it. So that means you're more prone to having flare-ups throughout your life. You're more prone to having less efficient and sufficient pain control movement. So we actually get into the joint and treat it, your results are better, longer lasting, and maybe permanent. It might be all you ever need, but we got to get to you early, okay? So we now recommend this as a first-line treatment. So you get diagnosed with an intra-articular TMJ disorder. Treating this as a first-line option with minimally invasive surgery is one of your 2 options: non-surgical, minimally invasive surgery. Or if you're just not getting better at that 12-week mark, we need to start transitioning to this to help you get better, avoid expense, avoid pain, avoid development of chronic pain. Okay, more advanced TMJ surgery, there are other things that we can do. So generally more advanced conditions, so trauma, fractures, tumors, cysts, growth disturbances, etc. Idiopathic condylar resorption is a big one. So what are we talking about with these things? Open arthroplasty just means we're actually, contrary to putting little instruments in and having tiny little incisions, we're actually making an incision going into the joint. What you're seeing here is a disc repositioning. We're tying the disc back into position when it was out of position. I don't do this as much anymore. I think for most of us doing a lot of this is falling slowly out of favor. We do more disc removal and total joint replacement. But you can see even this, right after surgery, this is going to heal up well. This is going to be minimally visible. These scarring is almost never a concern for patients, okay? So don't worry about that. Meniscectomy or removal of a disc, do this much more commonly because it's just a little bit more predictable. Repositioning discs, I don't always know what's going to happen. You may get better, you may get worse, it may break, you may end up having to have the disc removed a few months to a couple years later. But if the disc is damaged, perforated, this is a good treatment option for you, okay? Total joint replacement, okay? There's a ton of myths associated with this that we need to kind of dispel. So one of them is that this is a last resort after everything has failed. Basically, these are people practicing like it's 1990, 2000, 2010 maybe, where it's just like, this is a last resort, it's evil, it's from Satan himself. And all the while you're suffering. It's so strange how we as providers are okay with you being in daily debilitating pain, having a poor diet, having no social life, often not having a romantic life, not having a job. You're not able to get on with your life. And we somehow feel like that's okay. But putting in a prosthetic joint that we know works and is safe is somehow evil. I again like to say that people who are treating TMJ disorders who feel that way about total joint replacement, it's kind of a quick, easy way to figure out who's really living in the real world and dealing with this frequently and following the evidence, okay? These will only last 10 years or people are too young. The reason we used to not put these in young people is because we only started putting these in the early 90s and we didn't know how long they were going to last. Well, we've now been putting them in since the early 90s and have over 30 years of evidence that many of those first ones are still around. So they're not failing. You might get decades or lifelong use out of these things. So because of that, we're putting them in younger and younger patients, okay? It's not safe and too risky, okay? Again, you can tell who's in touch and out of touch. 30 plus years of data on these, have an excellent safety profile, have an excellent longevity profile, and they're just our most definitive treatment. And here's an example. So here's a young patient who had idiopathic condylar resorption. Condyles were just melting away. So because of that, she had an anterior open bite. Look at the posture of the lips. Not a good aesthetic, not a good airway here, narrow airway, despite being slim, fit, healthy in early 20s. Prosthetic joints. Look at the facial balance now. Much better facial balance, even with swelling after the surgery. Airways much larger. Teeth fit together better. Can open, chew, bite, living life like nothing ever happened. Nothing wrong with doing this, okay? And what I like to always remind patients is this is our most definitive solution. What I mean by that is if we give you arthroscopy, arthrocentesis, open joint surgery, take your disc out, reposition it, most of the time, if we choose the right patient, you'll get better with those things. But not always, and how long and how much is difficult. With this, we really know how you're going to do, and it's well. You generally do very well with this, and we know that not only are you going to do well, you're going to do well for a very long time, because as long as the prosthesis holds up, there's nothing to go wrong. You don't get arthritis of a prosthetic. A prosthetic doesn't relapse. It doesn't resorb. And the function is excellent. So we do a lot more of this now, and that's just a way that we like to educate patients on this. So again, I'm Dr. Michael Wasson from Arizona Jaw Surgery. I hope this was helpful. I know it went a little longer than 20 minutes, but hopefully that provides some use for you and some tools to hopefully get better. Thanks.